Good morning. I'd like to call the meeting of the Minnesota Senate Health and Human Services Committee to order. It is Thursday, March 9th, 2023. We do have a quorum present. And our first bill on the agenda today is Senate File 1274, Senator Maye Quade. Welcome back to the committee.
Thank you so much, Madam Chair, members of the committee. Today I'm here to talk about Senate File 1274, which appropriates funding to the African American Babies Coalition through the Wilder Foundation. The purpose of this bill is to support prenatal and postnatal development of infants. And while the AABC serves the entire Minnesota community, it is very clear that increased attention is required on Black, Indigenous, and other communities of color. Minnesota has persistent and unacceptable rates of infant mortality and morbidity. Black and Indigenous infants are twice as likely as white infants to die before their first birthday, a result of decades of negligence regarding preventable health inequities. Prenatal and postnatal gaps in healthcare exist even when accounting for healthcare access, general overall health, mental health status, and other risk factors. Culturally specific healthcare is needed to address ongoing health disparities, and this bill is just one piece of that puzzle. This bill continues an appropriation for the African American Babies Coalition, who offers culturally specific strategies to a broad coalition of communities through community-led training, sharing best practices, and other supports that mitigate disproportionate negative outcomes in infant and maternal mortality and morbidity. The African American Babies Coalition continually partners with communities to connect families with local and state resources, and I really urge the committee today to vote yes on this bill so we can continue to support the work of children and families. I do have a testifier here from the African American Babies Coalition to testify on the bill, but one of the things I just want to note is I am a Black mother, I have a Black daughter, and one of the scariest parts about giving birth was knowing that for all of my education, my privilege, my health care, my health insurance, none of that actually protects me or my baby from some of the most devastating outcomes, because even when you account for those things, you know that your race actually just is part of the devastating inequities that happen in this state and in this country, and it's really scary. And so we have the opportunity today to support one of the groups that's really helping decrease those inequities and make sure that people survive and thrive in this state. So I will invite my testifier to come share more.
Thank you very much. Angela Moore-Smith. Welcome to the committee, and please state your name for the record, and you can begin your testimony.
Yeah, thank you. Good morning, Madam Chair, members of the committee. My name is Angela Moore-Smith. I am the Senior Program Associate for the African American Babies Coalition and Projects, also known as AABC. I'm responsible for the recruitment of our community trainings, our communication, and also our media. I am also a local community resident of St. Paul, a former early childhood educator of over 10 years, a wife, and a mother of 4-year-old twins. I am here today in support of Senate File 1274. The provisions in this bill will help AABC to continue to build in capacity to further train, educate, and improve practices among Black, Indigenous, and persons of color during their pregnancy and postpartum. AABC began in 2005 with the mission of addressing Black and brown families' awareness of healthy brain development. This begins after gestation, during delivery and postpartum, and throughout a child's life. AABC's work is centered in prenatal care, social determinants of health, focused awareness of parenting, and reducing the education and economic gaps in both Black, brown, and communities of color. AABC is working to create an equitable healthcare system that has the capacity to provide culturally responsive care so that Black, Indigenous, and families of colors can thrive. We have developed in the past 2 years added work to our responsibilities. These include the development of 3 training curriculums, culturally responsive focused training for healthcare workers, community members, and families, providing healthcare and university customized staff and public training, action luncheons, summits, forums, and advancement gatherings. We have piloted and created 2 early childhood library sites to promote early literacy and nighttime bonding with caregivers and their children, and also partner in creating and distributing a My Baby and Me building bag for postpartum mothers and newborns. We have also contributed material for the Women's Economic Security Act and continued media, as well as hosted an annual 2-day Black and Brown Birth Conference with over 175 people in attendance. Black and Indigenous communities of color face persistent health disparities in birth outcomes, infant mortality, and child development stemming from lack of access to high-quality, culturally sensitive prenatal, delivery, and postpartum care. Research shows us that in Minnesota, according to the March of Dimes, in 2021, 1 in 10 babies were born preterm. 1 in 14 babies were born had low birth weights. And in 2019, 299 infants died before reaching their first birthday. An infant mortality rate of 4.5 per 1,000 births. During 2017 and 2019, the mortality rate in Minnesota was the highest for American Indian and Alaskan Native infants at 11.5, followed by 8.5 for Black infants, 6.5 for Asian and Pacific Islander infants, 5.9 for Hispanic infants compared to 3.6 for white infants. Our babies deserve better. Voting in favor of this bill will help AABC's work to help mothers of color have better access to referrals for specialists and other resources and services that they desperately need, increase access to high-quality services in communities of color, and help us assist clinics and hospitals in providing training so competency keeps building and not just at the bare minimum. Help to train hospital administrators in prioritizing Black, Indigenous, and mothers of color, provide healthcare and childcare providers with access to the best scientific evidence to guide their care. And last but not least, this bill will help us meet our long-term goal and mission for the disparities in prenatal birth and early childhood outcomes for Black, Indigenous, and babies of color in the state of Minnesota to be reduced and, better yet, eliminated. AABC and projects are intended as a vehicle for easy access to guide mindfulness and a safety net with an opportunity to design innovative tools to help our community thrive. We are proud of our connected-based work and hope you will join us in this work to be extended and implemented. Thank you to the committee members. I urge you to vote in favor of Senate File 1274. My director is joining virtually. Samira Bilal Roby and I are happy to answer any questions that you may have about AABC and projects. Thank you.
Thank you very much for that presentation. Members, do you have any questions about this bill? Senator Udke.
Thank you, Madam Chair. And we've seen similar type bills like this, and my opinion on them hasn't changed, and that is the fact that I don't like these that are singled out to certain races. I think it's more fair if it's communities, neighborhoods, zip codes, because we've got areas that need help, are suffering, but I don't think drawing a line between races is the right way to go on that, but that's, so I won't support the bill just because of that. It's not that it's a good idea. I wished it was more inclusive, but I do have a comment related to the fiscal note that I think should be addressed. It's calling for 0.15 FTE and $28,000 for the administration of this. It's going to one nonprofit or one foundation. I don't think the department needs $19,440 a year to cut a single check and follow up on a single grant, plus take a $28,000 administration fee. As far as your bill goes, Senator Maye Quade, I think if we're going to make the appropriation to the foundation, they should get it all, and we shouldn't have to be paying these fees for such a small amount of work. So that's just my opinion. I think you could gain more for your foundation than what they're allowing you to do. So just my comments. Thank you.
Senator Maye Quade.
Thank you, Madam Chair. Senator Udke, the first thing I'll say is that the reason why we're targeting this grant specifically to Black, Indigenous, and Brown families is because the way that the death disparities and the morbidity disparities cut are along lines of race. And it doesn't actually change when you account for wealth or mental health status or zip code or education or marital status or any of those things. The death and morbidity disparities among Black, Indigenous, and brown infants in this state are high regardless. And so that is why we're targeting it here, because we actually have to change the systems in order to decrease those deaths. And I believe part of the reason why the 0.15 FTE is here is because it's on a quarterly basis, and just to make sure that there's technical assistance and fiscal reconciliation. So I think we want to make sure that there's strong and good oversight of the grants we have going out from our departments.
Thank you. Senator Oetke, any further questions?
Thank you.
Senator Abler.
Well, thanks, and thanks for coming. And just to the fiscal thing, Senator Oetke and I couldn't agree more. We have written bills. We think we're sending money to a group, and well, in a different hearing, Madam Chair, or a different time, maybe even offline, I will predict you're going to have to put a RFP together to get the money that we're wanting to send you. That's what I understand how these have gone. We try to send money right to somebody, and like weeks and months go by while the money sits in the bank waiting to go out to what we thought we did. And it's been time and again. It's not just this matter here. And so the department sits on $28,000, which you don't have to decide who gets it. And so maybe you need to have a report supplied. But I mean, 28,000 here, 28,000 there, and a $17 billion budget, who cares? Actually, it adds up to a lot. It's 10% of your bill in one of the years, and real money. So it's not your issue here, but I just think authors pushing back and we as a committee pushing back, it's like, what are we getting for our money? To the bill, I'm happy to support the issues with disparities. And Senator Maye Quade, and I'm sorry I didn't catch your name. I'll have a question for you in a minute, but ma'am. But we have done so many efforts in so many ways to address this very problem. We spend literally billions of dollars on medical assistance money, which for the low-income side of families is how we pay for it. And so if indeed, we heard from the Department of Health that they're not going to where we would like them to go, that they're not going to the equity populations that we think they should be, even under administrations, the last several have not been to the right of center. Like, what? You know, and so what are we doing as a system here? And so the issue, so you're going to throw $250,000 at a problem that you could spend $500 million on to fix. And so I don't know what dent this is going to make. But the issue is, in our medical assistance system, are the rates so low that the specialists won't accept the patients, or are the networks too narrow because we're involved in managed care where every doctor can't be in there who wants to be in there in the PMAP programs, which I am not a fan of limited networks. Are there not enough doctors and clinics in the neighborhoods where people can be served, where they can retain? That's the bigger question that I think we need to be asking. And so I would be happy to vote for this. I think we're probably going to lay it over, and then the chair will decide what we're going to buy. So I didn't catch your name, but I have a question for your testifier.
It's Angela Moore-Smith.
Okay. So Ms. Smith, thank you. Ms. Moore-Smith, thank you for coming. And I appreciate your passion, and I hope you see that I get it. But I've been here 24 years, and my first year we had a health disparity bill about something, and it's not getting any better. So how many families do you serve in your agency that you help on an annual basis?
Ms. Moore-Smith?
I don't have an exact number for you right now.
You mean like 5 or 100 or 1,000? Just a ballpark. I don't
Ms.
know.
Moore-Smith?
You mean, are you saying per year, how many families we are?
I mean, it's how many families do you touch? I'm just curious how big your lane is, or how many families might come your way over a year.
If I may, I'll have my director, Samira Barla-Roby, she can chime in on and provide better context to that, if I may.
All right.
And she is on the Zoom link. Yeah, so, I'm sorry, her name again.
Good morning, everybody. So I want to
Please introduce yourself for the record.
We reach out to the workforce. Mainly, we do system change. So we, even though we're part of Wilder and we have programming where we work with literacy and the gaps, our main objective is the workforce having the appropriate training, skills. And I need to point out that we do go statewide. We do, and we include and are allies with the entire Minnesota community. In our writing curriculums, we address the rural issues with the workforce and training and healthy care of delivery of babies and the infant mortality. So we make sure, I want to make sure that you understand that we are not just addressing the African-American community or the communities of color. Our trainers, we train with healthcare, U-Care, we train with United Healthcare, we train with agencies, Ramsey, and we do not care who shows up in the room. We just want to make sure people have all the skills. So it is not a black and white issue. Our name is African American Babies Coalition, but we care about all children. So the families that we meet, if you ask me how many trainers we train per year, we're up around about 500. I hope that answered the question. And that's per year. And there's a turnover, and we are constantly adding new arms as we see new emerging needs in the community. If it's on communication, we do stay in our lane. That is why we did the PSAs, where we got the 2017 Academy Award with TPT. We stay in our lane, we get the messaging out, we do the training. That is how, and here's the thing, everybody, if I can say, I'm 69 years old. I've been doing this work for a long time. And I ask the same question, when are we going to get relief? When are the communities going to recover? The population and the number keeps growing. We know all around our population in Minnesota is growing. We have a lot of work to do. And that is where we are really directed to teachers, educators, healthcare workers. We train and design according to the entire population that has anything to do with mothers and babies.
Thanks. And just one thing else. So,
Senator Abrams.
and Senator Mann, you actually, maybe we can work on this together. I think your organization's a fine organization. I see the passion in both of you and in your voices and on your faces, and I like that. But Senator Mann and others, I don't know what we spend every year on medical assistance and how the system's working. It would be very helpful, Ms. Moore-Smith and the other woman whose name I didn't catch, tell us what's not working. How can we not getting the referrals? Tell me why on its face a person of color should be more at risk for any reason at all in a system that we have worked so hard to spend a ton of money on and with continually poor results. And so in return for the $260,000, if you could feed back to us where you see the gaps, and we can work on those here. And maybe maybe the fee-for-service system is better where people can go anywhere. Maybe managed care should be actually managing and reaching into communities at risk for the privilege of having the opportunity to serve those hundreds of thousands of lives. But we all care about this problem. So I'm going to stop. I don't want to burn up the day, but I just can't imagine us sitting here and doing more of the same thing and getting the same poor result. And so with the idea that you might feed back to us the gaps you see, then I'm happy to be supporting the project. Thanks.
Madam Chair.
Senator Maye Quade.
Thank you, Madam Chair and Senator Abler. So I'll just lay out some of the reasons why that do need to be addressed. So I was 5 weeks pregnant the first time I was called the N-word. Not the first time, but the first time during my pregnancy. I was 5 weeks pregnant. And racism is literally a public health crisis. And so when we're talking about preterm birth, low weight, we have bulldozed entire Black communities and then built highways right through them, and so there's increased pollution in those neighborhoods, which contributes to higher rates of asthma and health outcomes, poor health outcomes, which can lead to early delivery, preterm birth weight, preeclampsia, which I also had. We know that, I think it was a recent study that said 50% of medical students who are going to be doctors still believe that Black people feel less pain in their skin because it's Black. These are systematic problems that exist within our system that it doesn't really matter how much we it does matter how much we reimburse for MA, but this actually isn't about like the money that's going into medical assistance, which like white and Black and brown and Indigenous and Asian and Latino Minnesotans access. It's not specifically that healthcare, but it is about the systems that surround and wrap around these families. And so what AABC is doing is actually getting to the folks who are within that system to train and educate and work with them to make sure that the systems that do wrap around these families understand what is happening and can be part of the solution. And so those are just a few of the examples that I can give you about where the problems are. It's not MA or the healthcare, but it is the literal systems that are wrapped around every single Minnesotan that were built on legacies of racism and white supremacy. And so they were specifically created to give these outcomes. And so when we do things like this, we actually are contributing to being part of the solution to fix it.
Madam Chair.
Senator Abler.
I think it's horrible anybody would call anybody any epithet. I think it's terrible that anybody would call anybody the N-word or any other of a variety of words that describe their ancestry. We're beyond that. I actually do not believe that the average medical student, half of them think that skin color determines how palpable sense of pain. We could drag them up here and ask them that question. I would be shocked. And I don't think so much of this is any kind of institutional racism thing. I think we got some systems problems, and we got to address those. And everything in the world that's wrong with it is not because of racism. And we're not going to debate that today, but we're going to have more discussions about this because it's coming up so often. But we have to figure out a way, help doctors help these fine organizations like you have here, make sure that people do the right thing for the right people. And at the end of the day, we need better outcomes. I want no unborn baby to die before it's born. I want no baby born to suffer an untimely death because of any reason. And people of all races live next to those bad places. And if there's an issue, if there is some racism in people, in the behavior of clinics, if it turns out that more people who are Black don't get to go to the specialist they ought to, I have a problem with that, and we can control that here. So thank you.
So, Senator Abler, just a couple of those points. Essentially, modern gynecology was built on experimenting on Black women. Dr. Sims, who is the father of modern gynecology, performed his surgeries on Black women without anesthesia to see, how much pain they could tolerate, because he didn't believe that Black women really had felt pain, but also to perfect these surgeries so that he could then turn around and perform them on white women with anesthesia. We have the Tuskegee experiment, where we infected Black men with syphilis and watched them die to see what syphilis looked like. And in the middle of that experiment, we knew people were dying, and instead of saying, hey, we can treat this will be easy to treat, we can say, no, they let them die without treatment. So, and then recently, very recently, and I can't remember the year, but it was within the last 5, a survey was done for medical students. And they asked the question, do Black people feel pain at the same rate or the same amount as white people? And half of the students said no, which is shocking and unacceptable, but that just happened. That wasn't 10 years ago, it wasn't 30 years ago, that just happened. So, we talk about we spend money on MA, but we don't spend time or money on resources, or we don't spend our time or money or resources on systemic racism. We don't discuss weathering. We don't spend resources on prevention and system changes. And then we say, well, we've done everything we can because we don't really believe that racism is a thing, and this must be something else going on, despite the fact that when we do studies and we control for education and income and zip code and everything else, Black and brown people still have worse outcomes, right? And Black and brown babies and Black and brown moms continue to die at unacceptably high, disproportionate rates compared to our white moms and babies. And so this argument that we've done everything we can, we spent so much money, what else can possibly be done? There's so much that can be done. There's so much that can be done. Again, having these conversations is one of them, because again, when it doesn't affect you, you can't possibly believe that people are being called the N-word, because it's not something you would ever do, so why would anybody else ever do that? People do it, and they do it often, and it takes a toll on your health. And so I appreciate us having these conversations out loud because I think they're very important. But this bill and this organization is just a small thing that we can do to start tackling this problem. It's not about being fair, right? It's not about spreading the resources to everyone. We have a group of people who are dying at an unacceptably high, disproportionate rate. That's where we have to invest money. It's kind of a no-brainer for me. So thank you for this bill.
Madam Chair.
Senator, can we move on to the next senator?
Just something. No, then I'll stop.
Okay.
Dr. Sims was in 1876.
Uh-huh.
So I don't mind talking about that. I don't mind talking about horrors of the past. If indeed in modern times, today when we're here, there are students who think that half of people of color feel pain different, well, that's incredibly horrible. But if indeed Blue Cross is not serving the clients as well because of some color thing, that is unacceptable too, if our model is wrong. I'm not saying we've done all we can do at all. I sit here, I've tried to be transparent, and I do care deeply about this. I'm a life guy. And we've had other discussions about life, which is not part of this discussion. I think life should be protected everywhere, by everybody. And, I'm not even going to that other word I was going to use. So I'm willing to be a part of the solution. I'm willing to sit here and interrogate UCare and health partners and everybody and say, what on earth are you doing? Tell me your health disparities by race. And what are you doing about it? And then maybe they are doing something. If they're not, it's our job to do that. And it is unacceptable, Ms. Moore-Smith, for these statistics to be. And they have been there. I'm just telling you, we try and try and try. And so maybe the small amount of money we're going to give you is going to train a few people to understand a little better. If they have to be trained to understand, we got to have to be about it. But it has to be where we come together and we decide hand in hand, arm in arm, that we're going to make a difference about this. And I'm here committed to that. And Senator Mann, that's why I included you, because I know you know the industry and I know you live in it. But I'm going to announce to the medical schools of Minnesota, if you think that I just can't believe that we're that backwards. So, I mean, I'm going to, Dr. Toller, come talk to me. If that's true at your medical school, then we are going to hammer on you all to get a clue. So I'm done, thanks.
Senator Hoffman.
Thank you, Madam Chair, and thank you. You said the one thing that popped in me was you said system, and I'm going to give a little system statement and then a question that's part of the system, right? Since 1935, maternal child health outcomes have been part of states' discussions. The federal government gives the states and says you have to reach certain national performance measures. You have to set health indicators, right? And it's a no-brainer that Minnesota should be addressing what you're addressing in their Title V federal block grant. And this is where I think the Department of Health, in their 2023 snapshot, in their application to the federal government, not that I would ever read that stuff, but I do this. They indicate that birth outcomes have increased for everybody except the individuals that you were talking about here, right? But then I look at their performance measures and what they're doing. So they make the statement, they tell the feds, yep, we've seen a decrease, but it hasn't been that same way for Indigenous, African American, right? It's in there, right? And it's in, if you look at, and you can just do a Minnesota Title V state snapshot, and you can look to see what their application to the feds were on that. And the feds give Minnesota $9 million to help enhance their Title V public health system. And there are three things that jump out. And I love this statement: healthy development of babies during pregnancy, postpartum for family members, and then you address Black, Indigenous, or people of color, right? So now Minnesota identified that, right? But then when I look at what is Minnesota measuring, right, they have three things that they're looking at: the infant mortality, parent support, and care during pregnancy and delivery. Those are three things that the national performance measures all identify. Yet, why is it that we are having to have this? I mean, it's almost, where's the Title V? Where's Title V in this? I'm just going to keep yelling at, where's Title V in this from the state of Minnesota? Because it's the system, right? It shouldn't be like we are now taking a can of corn and we're putting it up here, but we're not putting it with the other can of corns, right? I mean, we're not identifying or lining it up. I love this bill. I want the system to be on board with that. You identified, Minnesota, you identified that this is a need, but yet your actions, not your actions, but our actions really aren't addressing that. And federally, states, you look around the different states that I got to review on Title V public health grants, and they're addressing that within there. And I'm going to go in the weeds on Minnesota to see if they actually have addressed that in there. It'd be great if somebody from Title V could say, nope, we are addressing it in here. So then if they are addressing it in there, right, they state it, but what's their action plan? I haven't dug deep in it. But why would it be for us to bring it forward? If they're already doing it, then here's my challenge then to the department. They should be pulling in this piece and saying, yes, this is now going to be part of our Title V. And if it already is, way to go, right? Then I would ask the question, what about that $9 million? And then the state has to match. There's $10 million in different other services that are matched to that, right? Unlike the state of California leverages $38 million from the feds into a $4 billion system of Title V. You look at the state of Washington, you look at these different states that are they're leveraging that piece. In this case, I'm asking the challenge question: are we leveraging what we know exists out there? Because you identified it in your 2023 snapshot, state of Minnesota, right? But how are we addressing it here? I want to see this program established within that Title V. I do personally want to see that because it would make sense to me, right? Yeah. And so, they're already receiving, the 0.5, the conversation about the staff thing, right? But it's really, I think, I would love to see public health say, yep, this is, and maybe they already are. Again, I'm rounding and round and round. I just want to say, I love what you're doing because you're addressing something that we knew needed to start to happen in 1935. When maternal child health was on the Social Security Act, that's where Title V was put in, right? And it was to deal with the specific birth outcomes. The other thing I love about Title V is 1/3 of all those program dollars should be going to children and families, children and youth with special health care needs. Nobody else is doing that, right? And I mean that. Title V, I happen to love Title V, and I love what you're doing. This is Title V. How can I help make sure that the system is doing it? Because you brought it. You're spot on that, Aaron. It's like, the system, what is the system doing? We shouldn't be lining up separate cans of corn. We should actually looking at how are all the corns lined up in the kitchen cabinet side of it, right? And if I keep using that analogy, to me, that's the visual of opening up. Anybody open up their kitchen cupboard and try to find something? Well, guess what? It shouldn't be over here. This should be right in there. Does that make sense? So whatever I can do to help on this bill, this is absolutely a wonderful piece if we stick within that Title V side of it. So hats off to you on that one. So.
Thank you, Senator. Any other comments, questions? Senator Maye Quade, closing comments.
Well, thank you, members, for the robust discussion. I think we were able to talk about some things that are really important. I really hope you'll support Senate File 1274 and this really important work that they're doing.
With that, Senate File 1274 will be laid over. Thank you, Senator Maye Quade. Next up, we have Senate File 1590, Senator Champion. Welcome to the committee.
Good morning, Madam Chair,
Good
Committee.
morning.
Thank you so much for having me this morning. Thank you. Thank you so much for taking the time to listen to Senate File 1590. Madam Chair, I'll give some context if that's okay, and then I have some testifiers who will keep their testimony to 2 minutes or under. So Senate File 1590 is a request for the African American Child Wellness Institute. And there's a request for an appropriation because it's a grant to the African American Child Wellness Institute, which is a culturally specific African American mental health service provider that is a licensed community mental health center specializing in services for African American children and families of all ages. One may ask the question, because I heard the robust conversation that was just held, why this institute would be important and necessary. And I'd just like to call your attention to a report that the U.S. Attorney General's office, they had a National Task Force on Children around those being exposed to violence. And the majority of children, it says, in our country who are identified as having been exposed to violence never receive services or treatments that effectively help them to stabilize themselves, regain their normal developmental trajectory, restore their safety, and heal their social and emotional wounds. But help isn't optional or a luxury when a child's life is at stake. It is a necessity. For many victimized children living in survival mode, constantly reacting in the flight or fight response, even when danger is not imminent, may fundamentally alter the rest of their lives, derailing their psychological, physical, and social emotional development. That report was done in 2012, and I thought I would cite something from there. And Madam Chair, the African American Child Wellness Institute was established in 2007. They're a 501c3. They're a community health center, as I mentioned earlier. And why they are necessary is because they promote the psychological and spiritual liberation of children of African descent and their families by providing culturally specific mental health services and by developing access to culturally based holistic wellness resources, research, and practices. It improves the lives of not only children, but of their families. And with that being said, I think it's also important that we understand that African American children and families in Minnesota experience severe disparities in multiple systems, including education, foster care, criminal justice, and mental health. What this institute also does, in addition to providing direct services for families and children, they recognize that there's a shortage of mental health providers of African descent. And with the average age of current providers being around 64, problems with developing a pipeline to mental health fields exist. And so they intentionally infuse that element in their delivery because we also think it's important for there to be a pipeline. Last thing that I'll say, in the African American community, there's the stigma around mental health services and if you're going to get treatment or see someone. We think that it's important for us to have intentional strategies by which to address this issue on multiple levels, and this institute does that. So with that being said, Madam Chair, I'd like to have Dr. Bravada Akinsanyan, who is a PhD. She's the executive director of the African American Child Welfare Institute, to talk a little more about it. And then following her, to my left is Al McFarland, who is board chair and president and CEO of McFarland Media Interests. Madam Chair.
Thank you, Senator. Dr. Garrett Akinsanya, if you would introduce yourself for the record and proceed.
Thank you so much. My name is Dr. Bravada Garrett Akinsanya. I'm an executive director of the African American Child Wellness Institute. And I'm here to speak to you in honor of our children and our families and in support of SF 1590. I'm a licensed clinical psychologist and I've practiced for over 40 years. And I have all that experience in the field of mental health, serving clients from ages from birth all the way to death. So that range in our clinic covers the developmental spectrum of early childhood all the way up to geriatrics. I'm a fellow of the American Psychological Association and a board-certified diplomat and fellow in African-centered Black psychology. I am also a past president of the Minnesota Psychological Association, the first Black president after 75 years. I am also a former president of the Minnesota Association of Black Psychologists. So I have written, presented, and consulted extensively in the areas of developmental psychology, women's issue, trauma, community violence, multiculturalism, poverty, homelessness, severe psychopathology, and African American mental health. Our organization, ACWI, has been introduced as a Rule 29 Community Mental Health Center, and I believe it is one of maybe two in the entire state of Minnesota that focuses on African or people of African descent. We're specifically dealing with children and families who are of African descent. We provide mental health services across the state, reaching clients in places like Rochester, Mankato, St. Cloud, Duluth, and the metro area. Our mission, again, is to promote the psychological and spiritual liberation of children of African descent, as well as their families, by providing these culturally specific services, wholeness resources, research, and practices. So we hold an ecological perspective of wellness that is inclusive of all areas of one's life. Through a recent DHS grant, it's the CEMIC grant, Cultural Ethnic Minority Infrastructure Program. ACWI, our organization, has been able to provide clinical and ancillary services to children and families who are uninsured or underinsured. There is a large majority in our state of working folks who have insurance, who work at large organizations, but the insurance that they have is inadequate for them to seek services. They have $7,000, $8,000 deductibles and co-pays of $50, $75. And they come to the clinic after experiencing a trauma. In their family, their children need help. The parents need help. They can't afford to come three times a week for Jimmy and Dwayne and then the parents. They can't afford to be spending $200 a week to come in for a therapy session. Plus, they can't meet the needs, the requirements of the insurance companies. So we are there holding them in that gap through our clinic. We also provide capacity building for licensure services for African American clinicians to gain training, clinical supervision, and culturally congruent, trauma-informed, practice-based, and evidence-based strategies. Through our program, we have trained more than 47 African American clinicians to go into the community. But due to inadequate funding for our program, we've only been able to keep one. And the one we got is because somebody gave us an external grant so we could meet the demands of the market. So I want to just briefly talk about the problem, and then I will close and always be available for questions. It is no secret, like Senator Champion said, that African American children and families in Minnesota, they experience severe disparities in multiple systems, including education, foster care, criminal justice, mental health. Sadly, a recent Minnesota student survey revealed that while 15% of Black ninth grade students reported having long-term mental health struggles, behavioral and emotional problems that lasted more than 6 months. Only 9% of them were able to access one single service, one single session. And so we need to look at the fact that these systemic practices, which have been discussed very well before I came to talk to you, those practices have a deleterious impact on African American youth and have a glaring impact on issues of safety, trauma, suicide, drug abuse, and exposure to violence. Our psychological research shows us that health outcomes for Black patients are better when they are treated by Black clinicians who are trained to work with them. That research is critical, given that the African Americans in the United States experience poor health outcomes across a variety of diseases and conditions. If we invest in moving and involve Black youth and families from the perspective of being at risk to the perspectives of being at promise, we can make a big difference with funding and support. So your support of SF 1590 will expand access to culturally specific and comprehensive mental health services for children and adults. It will increase the number of licensed mental health providers of African descent in the workforce who can render culturally proficient care to children and adults of African descent. It will support at-risk or at-promise parents, whether they face circumstances including poverty, mental illness, substance abuse, physical abuse, or physical health challenges. And finally, it will support the development of innovative, collaborative models for service delivery among people of African descent. And with that, I say thank you.
Thank you very much for your testimony. I had to step out, but I do want to let the committee know we do have several testifiers yet for this bill, and then we have several testifiers for the remaining bills on the calendar today. So I would appreciate if you can keep the testimony to around 2 minutes so that we can make sure we get through everybody's testimony. So next I have on the list Al McFarland.
Thank you, Madam Chair, committee members. Thank you, Senator Bobby Campion. I'll promise to keep my remarks less than 2 minutes, respecting your time and your request. I am the resident of North Minneapolis. I've lived where I live now since 1973. Tomorrow, my wife and I celebrate our 50th anniversary, and I say that to say that I'm vested as a parent, as a husband, as a resident, and as a businessman in our community. I have owned Inside News from the beginning, and we still promote the idea of identity, of opportunity, of elevating and celebrating Black culture throughout Twin Cities through Inside News and my other media programs. I'm pleased to have been invited to serve as the board chair of the ACWI, and my passion is that Dr. B and her team represent the opportunity for us to cast ourselves as the solution and not the problem. I'm here on behalf of the organization and in my role as a leader in the community, as an elder in the community, to say that we must begin to enable our community to see itself as the problem solver. And we step forward with solutions as a solution, and we invite you, ask you to support our capacity to serve our people. In serving our people, we serve you, we serve the state of Minnesota, we serve humanity. We ask for the chance to do that.
Thank you very much for your testimony. Next I have Kayana Kennedy.
Kennedy.
And I'm sorry.
Oh, she didn't make it.
I needed the Ricky. So we have Kalina.
We do have
Kalina
Kalina Peterson.
Okay. Thank you, and please state your name for the record and begin your testimony. Thank you.
Yes, my name is Dr. Kalina Peterson. Good morning, Chair, Vice Chair, and committee members. I am the current Assistant Clinic Director for the African American Child Wellness Institute. I am here as a former trainee for ACWI and in support of Bill SF 1590. When I decided to pursue an undergraduate degree in psychology, I could not fathom that I would be sitting here today with a doctorate degree and as a licensed clinical psychologist. I had not encountered a Black therapist or mental health professional at that time. I simply thought, I want to be something my friends and I wish we had while navigating life and the countless adversities we faced growing up in Gary, Indiana, a place that held the title of murder capital of the U.S. during my adolescent years. After completing my bachelor's degree, I entered a graduate program here in Minnesota to become a school counselor. There, I was taught by great professors with advanced degrees who were doing the exact work I desired to do. I was grateful for their education while I remained hyper-aware that none of the people teaching me or doing this work looked like me. I was introduced to Dr. Bravada Garrett Akinsanya during my last year of graduate school and interned at her practice. She was the first Black psychologist I'd ever met, and it was the first time I felt seen as a Black therapist in training. Dr. Bravado was everything I wanted to be and so much more. She taught me to relentlessly advocate for our people, not just in the therapist chair, but also through staff trainings, consultations, leadership roles, and community activism. My mind and eyes were open to the many possibilities this field of work held for me and the various ways I could be impactful and serve the Black community. African American providers are essential in reducing the stigma towards mental health and seeking treatment that continues to plague our people today. It was through Dr. Bravada's encouragement and inspirational example and the passion she has for this work that I chose to pursue my doctoral degree in clinical psychology. I am only one of many who have been inspired by her, and she has sparked the trails for countless practitioners of colors, and there's no way I would be where I am today without the culturally specific training and experiences with ACWI. It is absolutely crucial that funding be devoted to the recruitment and training of more African Americans in the mental health profession so that we can meet the demands of the African American communities and provide the quality care they deserve. There are so many more people to reach, and our work is far from done. Thank you for your time.
Thank you very much for your testimony. I have one last testifier, and I'm probably going to get the name wrong. Is it Ricky Ellis?
And Madam Chair, we'd like to replace Ricky Ellis with Mr. Akinsanya, who's the CFO of the Institute, and he's a data analyst as well. So he will keep his comments to 2 minutes.
Sure.
And I have my faithful clock on, so I know how that goes, Madam Chair.
Thank you. Thank you. Welcome to the committee, and please state your name for the record and begin.
Thank you very much, Madam Chair. Thank you very much, and Senators, good morning. My name is Akinyele Akinsanya, and I'm the Chief Operating Officer for the African American Child Wellness Institute. I'm responsible for the financial as well as the operational well-being of the African American Child Wellness Institute, otherwise known as ACWI. That's the acronym. Last year, our clinic provided approximately 8,874 direct hours of mental health sessions. Again, 8,872 hours of direct sessions. And we did this at a greater cost because, one, our clinicians were well underpaid. They worked under duress. You can check our records with the Department of Health and Department of Human Services. I'm not going to tell you how well we do, but you'll find us on the top of the list most of the time in terms of what we do, how we do it, and how much we do. So, if the legislature provides these funds, at least, or at the bare minimum, we'll be able to provide at least higher and pay competitive salaries to minimum of 5 doctoral level licensed professionals who will in turn be able to handle about 2 or 3 supervisees each. And these supervisees will be able to provide about 20 to 25 hours of sessions per week. So in essence, if you look at this conservatively, the licensed clinicians and their supervisees will at the minimum be able to provide between additional 20,560 or 42,120 hours, additional hours of services. These numbers will translate to about 217% or 434% increase in the service provision based on our figures, 2022 figures. If you really look at this, given what Senator Bobby Champion has said and Dr. Baroda has said, according to the Justice Policy Institute in 2020, the average state cost for securing a confinement of a young person in the prison is about $588 per day, which is about $214,620 per year. Compared to this boy coming to our center and having not just one session per week, one individual session as well as family sessions, we're talking about 2 sessions per week for the 48 weeks that we are open. The total cost of that for that family is only $11,118 compared to $214,620. So we spent almost 20 times to lock these young boys up in prisons when they can come and their family come to therapy and be rewarded as being good citizens, contributing to the society and providing economic contribution even to the society. So it's a matter of choice. Do we want to continue to just lock people up and spend $214,000 on them or provide services for them at $11,000? Thank you very much.
Thank you. Thank you very much for your testimony and for providing your insights into the value, the hours that you could add. Senator Champion, did you have other comments before we go to questions?
No other comments other than the fact that we think this would be an important resource for the community because we all would benefit. So we'll stand for any questions.
Members, any questions? No questions. No questions. Wow.
We're good.
That's good. And this is a bill that we will lay over for consideration for possible inclusion, and we can talk more about any of the fiscal plans and talk more with you about about how that would be happening over the fiscal years that are included in the bill. So, any other closing comments?
Other than I think this is an important resource, we believe that it is a great asset in our community and it benefits all of us. And we thank the committee and you, Madam Chair, for listening. And should you have any other questions, even once this hearing is over, I stand ready and willing to provide any information and to address any concerns the committee might have. Thank you so much.
Yeah, thank you very much. I really appreciate your time in coming and presenting on the bill. And I do see this as, it's a great need to be adding more capacity for mental health services within the communities that you're serving. And I hope that, if I have more questions, I will definitely let you know. So thank you very much.
Thank you all very much.
Thank you so much.
You're welcome. Next, we will we move to Senate File 2459, Senator Mann. Senator Mann's bill.
Thank you, Madam Chair. I do have an amendment. I'd like to move A1.
Just a moment. Let me get. So, Senator Mann, can you explain your amendment since this went to the Commerce Committee first and
Yes, Madam Chair.
Tell us about it.
Yeah, it's just a very technical amendment. We just had the wrong statute in there, so we just fixed that.
Members, any questions on the A1 amendment? Seeing no questions, all those in favor of the A1 amendment, please signify by saying aye. Aye. Any opposed? The motion does prevail. The amendment is adopted. Senator Mann.
Thank you, Madam Chair. Senate File 2459 aims to provide financial compensation through reimbursement of pharmacists who provide certain healthcare services to patients. This legislation is designed to promote pharmacists' involvement in patient care and improve access to healthcare services. Pharmacies are the most visited setting that Minnesotans will use for healthcare each year. Unfortunately, there are payers who do not recognize pharmacists and pharmacy services under Minnesota pharmacy scope of practice. So adding licensed pharmacists to the list of covered providers will ensure that Minnesota pharmacists and pharmacies are able to continue to provide care. These services are already being covered, so this is not a mandate, Senator Utke. And does not add any cost to the payers. With that, Madam Chair, I do have some testifiers.
Thank you. And the testifier, one testifier we have is on Zoom, Jason Miller. And if you could state your name, please, and proceed with your testimony.
Good morning, Madam Chair and committee members. This is Jason Miller. I am Clinical Program Manager for Coburn's and Cashwise Pharmacies, as well as co-chair for the Public Affairs Committee for the Minnesota Pharmacy Association. Thanks for having me here today. The language in Senate File 2459 that you see before you today will help local pharmacies stay in business and also allow patients to have access to care in their communities. I want to first thank you and previous members of your committee for passing legislation about 2 years ago to allow pharmacists in Minnesota to prescribe and dispense opioid antagonist therapy, nicotine replacement therapy, and birth control medications. In addition to these health services, we also provide health services such as the administration of medications, such as those used for mental health disorder and substance use disorder. And on the horizon, Minnesota pharmacists will work with at-risk patients to prescribe and dispense pre- and post-exposure HIV medications. This is Senator Dibble's legislation, which when used effectively and in a timely manner can all but halt the progression of HIV or AIDS. Of course, each of these services takes time, expertise, and have additional costs associated for the pharmacist and pharmacy. I like to share the example that at Coburn's, we did pilot a birth control service for our patients in 2 locations. The program was very much appreciated by our patients in giving them convenient access to care in our rural communities. Fortunately, when we tried to bill for the encounter, it rejected as not covered for provider type, meaning that most likely the service would be covered when billed by a physician or nurse in the clinic setting, but not by the pharmacist in the pharmacy setting. So then it becomes a cash-only business, which is less palatable or even possible for many patients. As you've probably seen in the recent years with the closures of all the Health Partners pharmacies, Lunds and Byerly's pharmacies, and Shopko pharmacies, we are not in a position to provide free services in order to prove our value to the healthcare system anymore. It's a very sore subject for us. Unfortunately, we lead the nation in the most pharmacies closed in the last 5 years. And so this has, of course, led to us not expanding this pilot. If this legislation passes, we will look at providing and expanding health services offered at our pharmacy locations. And I know my colleagues in many pharmacy settings around the state would do the same. We want to offer these health services to our patients, and patients want to receive this care at their convenient local community pharmacy. So thank you for your trust in our profession to provide care to our patients in the communities we serve. We also want to thank Medica and the Minnesota Council of Health Plan members, the payers, for also supporting Senate File 2549. We hope now we can follow through with ensuring pharmacist providers are reimbursed for the time, expertise, counsel, care, and administration of these services. We would be happy to answer any questions. Thank you, Madam Chair and committee members.
Thank you, Mr. Miller. Next, we have in person Matt Schaefer. Please introduce yourself and begin your testimony.
Thank you, Madam Chair. For the record, my name is Matt Schaefer. I'm the Government Relations Director for Medica, although today I'm speaking as a representative of the Minnesota Council of Health Plans. I want to start by thanking the proponents for initiating a dialogue on this legislation early and for continued discussions surrounding Senate File 2459. Members of the council raised a couple of questions and operational considerations, and the proponents incorporated some language in the bill to address those, and I'll touch on 2 of those. There's some language in Section 6 that was requested at the request of ensuring there are open lines of communication between regulators and stakeholders as this change in payment is rolled out. This will facilitate a process where all stakeholders can have a place to address any questions or operational considerations that may arise. As an example, do pharmacists want to use their pharmacist IDs or pharmacy IDs? Are we going to go through a credentialing process? And if so, what operational considerations do we need to have on our respective radars? And that brings us to the other request that we want to thank the proponents for, and that's moving the effective date to January 1 of 2025. If we have to choose between implementing a law right and implementing one right now, we're going to ask if we can do it right. And we believe that this extended time will give us time we need to make sure we're doing everything on our end to ensure a smooth implementation. And last, I want to echo the public health benefit, particularly as it relates to vaccine administration. We know that when you can make the healthy choice more convenient, that's going to improve uptake and that's going to reduce the spread of disease. I'll close the way I opened by thanking the author and the proponents, and I'm happy to answer questions.
Thank you, Mr. Schaefer. Did you have any other comments, Senator Mann? Members, any questions or comments? Senator Abler? Oh, no. No, I just thought there was an indication that you had questions or comments. Okay. Senator Hoffman?
I love this. This is the, you know, as I'm talking about pharmacies, pharmacists and vaccinations, pharmacists and shots, right, you know, during the COVID thing. And it's like, now we're having a scope conversation here, and I absolutely love this. I mean, department's cool with your bill?
Senator Mann?
Nice job.
And actually, I don't think it's really a scope conversation because we already did that work a couple of years ago in terms of what the pharmacist would be allowed to do. This has more to do with what the coverage and the payment of the services.
You're right, Madam Chair. That's within, I should have used the word within the scope. You've already had that.
Correct.
It's just nice to see that, so thank you.
Senator Utke?
Thank you, Madam Chair. I couldn't disappoint Senator Mann, and the green tabs just means go for today. Thank you.
Any other questions or comments, members? Senator Mann, I guess closing comments?
No.
No? Okay, I want to say we're going to lay this bill over because I want to look into the impacts on the MA and medical assistants and just make sure everything is clear on that. So, Mr. Schaefer, I'm understanding that there's not any further questions or concerns about the language at this time. Is that correct?
Madam Chair, not from us.
Okay, thank you. And with that, members, we'll lay the bill over for further consideration. Next, we have Senate File 1958, Senator Morrison. Welcome to the committee table, Senator Morrison. Please go ahead and present your bill.
Thank you, Madam Chair. Madam Chair, members, Senate File 1958 is a bill to establish clear regulatory guidelines that are designed to apply to a new geothermal heating and cooling technology called a submerged closed-loop heat exchanger that is sustainable, renewable, and has zero emissions. The Department of Health is responsible for the regulation of both the installation of water wells and the installation of geothermal units. The new technology consists of a geothermal unit that is installed and operates inside a conventional water well. Currently, there are rules governing water wells and rules governing geothermal devices, but there are no rules that govern a combination of the two. This bill is designed to remedy that situation by establishing a clear regulatory structure over the combination of a water well and a geothermal unit. And Madam Chair, I have two testifiers. Brian Larson is the Chief Executive of Darcy Solutions, who will tell you more about the technology that his company developed. And Bruce Cleveland can further explain the language in the bill.
Thank you. Welcome to the committee, and please state your name for the record and begin your testimony.
All right. Well, good morning, and thank you, Madam Chair and committee members. My name is Brian Larson, and I am the co-founder and CEO of Darcy Solutions. We are a technology spin-out from the University of Minnesota, where our groundwater-based technology was developed by leading research scientists in the Department of Geology. You have that handout in front of you where you can see our technology represents a significant breakthrough opportunity to reduce our carbon footprint by making geothermal, also called ground source, heating and cooling viable for commercial and multifamily buildings. These are market segments that currently typically don't have geothermal alternatives because one of the biggest challenges they face is the large footprint required to drill and install the boreholes for this. The Department of Energy has identified geo as the most energy efficient and environmentally friendly heating and cooling technology. As such, they have been very supportive of our work. They, together with the National Science Foundation and the USDA, have provided Darcy with over $3 million of funding to develop our technology. The state is also a big proponent. Minnesota DEED sees the potential to create a viable business, and they have supported us in developing this for the climate tech economy, both through research support as well as angel tax credits. And the Department of Commerce is also supporting our work because they see the potential for the technology to enable the efficient electrification of building heating and cooling. So together, the state has provided Darcy nearly $1 million to support the development of this technology. We have the opportunity as Minnesota to be pioneers and industry leaders and to support the capture of a much greater share of federal funding, including funding for district and community heating and cooling systems, items which are included in other bills currently before the legislature today. So I just want to emphasize 2 points. One is that because it was invented here by researchers at the U, these are researchers who have dedicated their careers to ensuring that we protect our precious groundwater resources, and that they have done this out of a desire to more efficiently use our shared energy resources under the competency of professionals who understand what it means to implement a safe and effective solution. We strongly support the Department of Health's mission and strive to be a dedicated partner to help protect our state's groundwater. The second point, as Senator Morrison laid out in her opening comments, is that the well code does not conceptualize technology like ours today. It does account for traditional geothermal, and it does account for water wells individually, but not their combination. And this uncertainty has created some reluctance on the part of the market and on the part of building owners to adopt this technology. So we're looking to bring that certainty into the market. We strongly support the rulemaking that would follow the passage of this bill to bolster the well code and implement a practical and scientifically sound performance measure. Thank you again for the opportunity this morning. I'll turn it over to Bruce Clavin.
Thank you for your testimony. Mr. Claiborne, did you have additional testimony?
I do.
Please
Thank you, Madam Chair. Bruce Clavin, I represent Darcy Solutions. This is my third year sitting in front of legislative committees trying to get this problem solved. Senator Utke, you're going to recognize Senate File 1958 because this is exactly the language that was in the Senate side of the conference committee side by side last May. The department didn't agree. We hadn't got an agreement, but what we did this year was picked up that exact language and reintroduce it because the reviser was so backed up. We wanted to get something in the file. And so what you see here is what we had last year. We're working with the department. And so I wanted to walk you through the bill here quickly. Section 1, I don't believe we have a disagreement. That's the definition of the technology. Section 2 simply moves temporary boring because that used to appear in Section 1. And number 3, specifically allowing it inside a water supply well. Now, as Brian mentioned, there's clear rules on drilling a well, and that just requires notification of the department. If you do a conventional bored geothermal unit, there's a permit for the construction, or if you do a groundwater thermal device, there's also a permit program. But all that would require here for the drilling of the well is a notification. What we're still working on is the stuff in Section 4, page 3, Section 4. What we had last year, and again, we did not have an agreement with the department, is mostly on subdivisions 4 and 5. The permit, the reason we had this language last year about the permit is we didn't want to get into a 2-year process of developing a permit at the department. We were trying to get the legislature to settle this for us to get this stuff moving. And the same with the variances. For the past 2 years or so, the only process available to the department and to Darcy essentially has been a variance, because there was no statutory provision for them. And so we've been kind of operating in this odd gray area for the last 2 years. And so we're continuing to talk with the department. We hope to have, by the time the markup is going to happen here, some agreement. Ultimately, though, you may have to make some policy calls here if we just can't get there, but we really are trying to do that with the department. To close out here, some of the things we're still talking about is the kind of fluid that would go in the tube, the blue one on your picture there. In the red tubes, I understand that there's anti-corrosive devices and things that can be put in there. The question for the Darcy system right now is just water, and if there's just water in there, can anything happen to it? Will there be leaks? If there are, what happens when that happens? None of us want to be on the front page of the Tribune above the fold with a problem in the aquifer, neither Darcy nor the department, and so we're trying to work that out. We're also discussing whether this should be a provisional program or just an outright program. Should we start installing them? I know the department prefers a provisional or a pilot program with a cap number. So we're talking through that. We're also talking through setbacks. You can see on your diagram there that the Darcy system has to have setbacks. The wells, if you're going to use it for potable water and withdrawing wells, there's various setbacks, and so we're discussing that. And finally, just the monitoring and reporting requirements. The department wants some more information. Again, I'm not speaking for them, but we understand they want more information about temperatures and how the system works, and that's partly what they'd like to study. And so we're continuing to talk, Madam Chair and members. I do want to thank you for the hearing before the deadline. I stopped by Ms. Burke's office the other day and made the pitch, and I appreciated getting on the schedule today. So with that, we'll stand for questions.
Thank you. Thank you for going through kind of what the open question areas are. I appreciate that. Senator Etke.
Thank you, Madam Chair. And yes, this does look very familiar. We spent a lot of time on it last year. It was a good bill last year. It's a good bill this year. Question for you. We know what stalled it last year. Are we having any success in the other body?
Mr. Claiborne?
Sure. Madam Chair, Senator Etke, we wanted to make the deadline in the Senate, and like last year, we focused on the Senate. We don't have a hearing scheduled in the House for the next 2 weeks. With any luck, we'll be on the Senate side by side again and ultimately try to get this done in May. The House hasn't had any movement last year or this year so far.
Okay.
Senator Etke.
Thank you, Madam Chair. And yeah, hopefully there's a little more push because like I said, it is a good deal, and it's time we move this forward and take advantage of this technology. So thank you.
Madam Chair.
Senator Morrison.
Thank you, Madam Chair. I would just add, Senator Etke, that we have 2 House authors, both of whom are leaders in the climate movement, so I'm hopeful that we will be able to move the bill in the House as well.
Thank you. Any other member questions or comments? Senator Morrison, any?
Madam Chair, members, thank you for your consideration of this bill. This is an exciting new technology that has real potential. Thank you.
Yeah, thank you, Senator Morrison. I, too, think that this is really, it's an exciting development, and I think that we should try and keep exploring, if we can get to agreement so that we can see this innovation move forward in the state and take advantage of future developments that are happening at the federal level. So I appreciate your bill, bringing the bill forward, and we'll continue the discussion, and we will lay the bill over for possible inclusion today.
Thank you, Madam Chair.
Thank you. Thank you, Madam Chair, members. Thank you.
Next, Senator Boldon. And I believe you would like to start with Senate File 2052. Is that correct?
Yes, Madam Chair, thank you.
And feel free to begin your presentation.
Thank you, Madam Chair and committee members. So before you, we have Senate File, we will start with 2052. So I appreciate the opportunity to speak about this. I first, maybe if I could, Madam Chair, would like to move the A1 amendment.
Let's see, I'm just getting to, that is in our packets, the A1 amendment, and this bill has not gone to other committees. 2052 is the one that we're working on. So members, you have the amendment before you. Senator Boldon, any comments?
I'm happy to just describe the amendment, and I'll talk about it in my description of the larger bill too, but the amendment strengthens sort of the language and the purpose of the bill. It adds ambulance services. It changes it to a competitive grant process and specifies that process a little bit, and I'll talk more about that.
Okay. Members, any questions? All those in favor of the A1 amendment, please signify by saying aye. Aye. Any opposed? The motion does pass, and the amendment is adopted. Senator Boldon, go ahead.
Thank you, Madam Chair and committee members. As someone who works in healthcare, this is an issue that is near and dear to me. This legislation seeks to appropriate $20 million in funding from the Healthcare Access Fund for provider types in the state to pursue via a competitive grant process to make safety enhancements in their locations. I appreciate you giving me a couple of minutes to describe why that is needed. The World Health Organization has stated that nearly 40% of those who work in healthcare roles have suffered a physical act of violence at some point in their career. That statistic would likely be higher if verbal aggressions were also captured. The American Medical Association has also noted that acts of violence against providers have been an issue that have escalated in recent years. And we've heard some testimony about that recently as well. These are difficult assertions to believe, but have been experienced by healthcare workers in our state. These acts can also be diverse, none of which should be condoned, but some could be a slap or a grab, while others lead to life-altering physical changes. I'd like to highlight a letter of support that's in your packet from a broad and diverse coalition that has been working with me and is supporting this proposal. As this letter reflects, workers in various roles, whether it be in hospitals like where I work, or clinics, long-term care facilities, or dental clinics, have been on the receiving end of acts of aggressions that shouldn't be happening. It's disheartening to live in a time where violence against healthcare workers has become something of a norm. While it's difficult to change human behavior, there is something that we can do to help healthcare workers remain safe. We can help them by providing a resource they can utilize to address safety concerns in their facilities. These changes may differ by location and type of care environment. Hypothetically speaking, a hospital may be interested in establishing a hospital-based violence intervention program. A nursing home may seek to undergo infrastructure updates to limit access points. A local clinic may want to implement de-escalation training for their staff. All of these options have costs, some of which are significant. This legislation looks to the Healthcare Access Fund as the source. This is a special revenue source that is dedicated to ensuring access to and quality of care in our state. Patients will not be able to receive care if their providers don't feel safe and if they don't want to work in these critical professions. And we've heard testimony about that as well, and certainly are well aware of the workforce shortages we're experiencing. So the bill before you includes additional distribution parameters that came forward after discussion with the Department of Health and discussions with the coalition. The idea was to frame the proposal broadly so that it could be applicable to a diverse range of healthcare workers and could be utilized to meet the unique needs of different operations across the state. I appreciate your consideration for this proposal and would like to introduce my two testifiers who can explain further the prevalence of this concerning trend and what healthcare organizations can do to ensure that their staff remain safe. We want our healthcare workers to know that they are valued and recognized and that we understand their concerns. And with that, Madam Chair, I'd like to introduce Dr. Casey Clements, an emergency department physician and the staff safety officer at Mayo Clinic, and Matt Horace, the chief security officer for Mayo Clinic.
Thank you very much and welcome to the committee. And please state your name for the record and begin your testimony.
Thank you, Madam Chairwoman. My name is Dr. Casey Clements. I'm an emergency physician and I serve as the staff safety officer for Mayo Clinic. I've been working on workplace violence in healthcare since 2014, including prevention, mitigation, and response efforts. The most recent data from the Bureau of Labor Statistics in 2018 shows us that 74% of all non-fatal injuries from workplace violence in this country happen in healthcare. That makes it among the most dangerous professions in the country. And I can tell you that the frequency and severity of those injuries is increasing significantly now. I could stand up here today and quote astronomical numbers of assaults that are happening daily in hospitals across our state, But in truth, we don't even understand the depth and breadth of the problem. According to the best available published literature, only 19% of physical violence events are ever reported. So we can take the numbers that are reported and multiply them by at least 5. This doesn't even hint at the injury, trauma, and fear that happens due to verbal abuse, harassment, intimidation, and threats, even terroristic ones, far more commonly that are even less likely to be reported. I can tell you of doctors who have gone home after their shift, packed up their families, and gone to stay in a hotel out of fear of such threats. We don't know what we don't know. What we do know is that violence has fundamentally changed the way that we interact with patients, that staff are suffering post-traumatic stress symptoms, and that a very high number of healthcare professionals have considered leaving their job due to violence, something everyone should be paying attention to in the current staffing shortage. We are caught up in an epidemic of violence against healthcare professionals that has gotten much worse since the COVID-19 pandemic, and yes, we have shown that the pandemic has increased violence in healthcare. Who is committing these acts of violence? I want to clearly state that violence is not strongly associated with psychiatric illness. I think that's a common misconception. Published data would say that at least in EDs, 70% of patients and visitors committing violence acts are lucid and know what they're doing. Instead, I want to tell you of the personal toll that this has played on the people who chose to care for all of us when we are sick and hurt. There is a nurse newly out of nursing school who is hit in the head and suffers long-term vision loss and isn't able to work anymore in the profession that they trained so long to do. There are broken bones from violence inflicted intentionally on multiple security personnel that will hurt them for the rest of their lives, and they aren't afforded additional protection by the current laws for penalties in our state. There are PCAs who are bruised and battered by dementia patients who have no idea what they're doing, but in a system that is not set up to care about that staff or that patient. SF 2052 offers a necessary first step towards helping the healthcare heroes that we profess to hold in high esteem during the COVID-19 pandemic, but who in reality haven't even been treated as breathing, feeling, or valuable human beings while at work. I would ask that this bill and likely future efforts that will be needed as well be supported to maintain our ability to care for you, for us, and our families when it's needed. Thank you for this opportunity to testify, and I would be more than happy to answer any questions and remain available if any come up in the future.
Thank you very much for your testimony. Mr. Horace, can you please state your name for the record and begin your testimony?
Thank you, Madam Chairwoman and committee. My name is Matthew Horace. I'm the Chief Security Officer for the Mayo Clinic, a position I've held for the past 4 years. As a 27-year veteran of federal, state, and local law enforcement, I understand all too well violence and victims. My role at the Mayo Clinic is to provide security strategy and oversight to people, process, and technology that will promote a safe and healing environment for the millions of patients that come to the Mayo Clinic for hope. My role is also to provide security oversight to the most important asset that we have, our employees, our physicians, our nurses, our technicians, all of our point-of-care personnel, and oh, by the way, my wonderful security team as well. They come to work every day to ensure that we provide world-class health care. We know that you cannot provide world-class health care if you don't feel safe. I read the reports and I watch the videos every day. The punches, the kicks, the strikes, the language, the threats, all perpetrated against people who have committed to the needs of the patient. And at the Mayo Clinic, the needs of the patient come first. We have access control and video management. We have programs and committees, protocols and procedures. We investigate every incident. We have amazing follow-through and follow-up. We examine, we study, and research better than anyone. What we don't have most often is the ability to foreshadow or predict when a seemingly calm patient or visitor is going to move onto a path to violence. When we do know that that possibly might happen, we collectively take the necessary precautions and risk mitigations. To that end, based on the alarming upward trending data, not just my organization, but all healthcare organizations throughout the United States need help. We must pull out all the stops. We must remove the barriers and add additional tools to our collective toolboxes. I share my colleagues' assertion that we support this bill. I'm happy to answer questions.
Thank you very much for your testimony. Senator Boldon, any other comments before we go to questions?
No, Madam Chair, we welcome questions or discussion.
Members, any questions? Senator Utke.
Thank you, Madam Chair. And I guess the first thing that jumped out at me as I was looking at the bill last night, line 1.8, where it says, including but not limited to. Normally, I don't like those type of things because where are the limits? I mean, the sky's the limit, but sitting with our members around the table, one thing that I don't see on here, chiropractic clinics might be another one, but I guess it would fall under the included but not limited to. But because ambulance service was now line itemed, maybe we should, if this was to become law, those things maybe should be more line item than eliminate that but limited to, because then everybody's going to be looking for it. But it's a serious issue. The core of the bill is good. The thing that will stop me in my tracks, and so I can't support it, even though the base of it is good, is cannibalizing the Healthcare Access Fund. Taking money from that is a non-starter for me. If we can find a different way of funding it, you'll earn my support. So just thank you.
Thank you. Other members with questions, comments?
Madam Chair, just so you don't
Senator Abler.
think I'm sleeping over here. I appreciate particularly the Healthcare Access Fund comment. I think you're going to have to decide what projects are worthy of funding in the priorities that you will have along with your caucus. So that'll solve a lot of this stuff. And narrowing it down to do the worthy goals is a good idea. But the Healthcare Access Fund, the governor went after $1.5 billion on top of 17 point whatever billion dollars. So I think if it could be the policy of this committee, we're just not taking money from there. I think that'd be a really good committee policy. Thank you.
Thank you. Any other questions? I guess I have a question about, it includes, this proposal would include a lot of different types of facilities. How well do you think across all these different types of facilities that they would have the ability to put together a grant request and apply for this type of a grant? And how well do you think, or how broadly is it understood, what types of programs or infrastructure improvements or IT system improvements are really going to be the ones that would make a difference in terms of addressing this issue? Senator Boldon.
Thank you, Madam Chair. I appreciate the question. I appreciate the discussion. I'll just note it sort of is intentionally broad in terms of the types of facilities. So it does list out some of the facilities and then does say, is not limited to, because that's intentional to leave it broad for, multiple types of healthcare entities. We don't want to leave anyone out necessarily. And in terms of, what they might use it for. Again, some of those are listed here, and I'll note that the dollar amounts is anywhere from $5,000 to $50,000, because, depending on what they're doing, there's that range of costs. And so it is intentionally not specific, because we don't want to direct what everyone is doing. We know that those entities will be the best ones to determine what works best for them and what is needed for them. And so, these are conversations that are ongoing at facilities across the state. This is a problem, as we, have shared, that is not new, but is escalating. And there are conversations about, risk mitigation and protection of staff that are ongoing and are happening. And this just provides some resources that those, organizations and entities and facilities don't currently have.
Okay, thank you. I guess then, to me, there is a, on line 1.20, there is a process that the commissioner will develop, a way to collect and evaluate results achieved through the use of the grant funds, which I think is really important, that we have some mechanism to understand how these resources have been used, and then what kind of results have facilities seen, by implementing them. So I think that would be really important to me, that there is a good evaluation process. Otherwise, I don't have other questions right now. I do think the funding source, is something that we would be further evaluating, where the money could come from and the amount. But this bill, we're intending to lay over today and then consider it for possible inclusion. So any other final comments?
I appreciate that, Madam Chair. I also would just again direct members' attention to the letter of support with the coalition. And so in terms of how to get the word out, I think that will be helpful as well. There's a large group of folks who have been working on this, so we'll help to spread the word. And I appreciate your words around the application process, that, we don't want it to be so burdensome that small entities are not able to take part. So certainly there's recognition of that. And I appreciate the discussion. This definitely is an issue that is prevalent. And so this is one avenue to try to get at that. So thank you.
Well, and thank you testifiers, and we will lay the bill over for possible inclusion at a later date. Thank you. Next, Senator Boldon, you have the next bill, Senate File 1489.
Yes, Madam Chair, thank you. And members, this is a bit of a sister bill to the previous bill. So as we have discussed, violence in care settings is prevalent and increasing. And while the previous bill focused on healthcare settings, this bill focuses on human service settings. And so it is, they are very similar. They are modeled after each other. But this one is targeted at human services organizations and services and providers, with the same goal of offering a competitive grant process for entities to have resources to be able to take action in a way that makes sense in their unique situations in their facilities. And so with that, Madam Chair, I will turn it over to our testifiers.
Senator Boldon, did you want to discuss and adopt the A1 amendment?
Yes, thank you, Madam Chair. I would move the A1 amendment, which I'll just say has come after discussions with partners. It just tightens up the language a little bit and puts the bill in the shape in which we would like it.
Members, on the A1 amendment, all those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Senator Boldon, did you want to move to your testifiers?
Yes, please, Madam Chair.
Thank you. And we have, let's see, I have Michelle Saint-Cartier. Please state your name for the record and begin your testimony.
Thank you, Madam Chair and members of the committee. My name is Michelle Saint-Cartier, and I'm the Director of Public Policy and Advocacy with Minnesota Social Service Association. MSSA is an organization of over 4,000 professionals from across the state who work in all areas of human services. I'm here today to urge you to support Senate File 1489, which would establish a grant to help ensure health and human services provider safety. I have a background in human services, hold a master's in social work and public health, and have worked in direct practice. Now, like many of you, I work in an office. I have assurance that I'll be safe at work. I've never faced any threat to my physical safety, and even when faced with some of the very interesting situations we all encounter here at the Capitol, I don't often face threats or significant threats to my psychological safety either. This isn't the case for many human services providers. Many don't have the assurance that they'll be safe at work. When they do advocate for their safety, they're sometimes even told that they're exaggerating, bad at their jobs, or even that they're bad people. The reality is unsafe situations in human services exist and won't go away by ignoring them. We've heard it loud and clear. This is a problem and it needs to be addressed now. Many MSSA members have bravely shared their experiences with us, including multiple members who were sexually harassed, a member who had a proposed date of death written on a billboard in the middle of town, a member who had major damage done to their vehicle, a member who was threatened with a gun, more than one story of a homicide in a facility where clients lived and providers worked, multiple members who were stalked, and many, many members who didn't have the training they needed to de-escalate a dangerous situation. Our agencies are desperately trying their best, but are under-resourced and understaffed. Senate File 1489 would authorize the Minnesota Department of Human Services to award grants to human services organizations to invest in workplace safety measures. Grants would be used to pay for safety training, safety equipment, facility safety improvements, counseling, and systems to track, monitor, and prevent safety incidents. We're proud that MSSA is leading this conversation about workplace safety for human services. The fact of the matter is, when we make the decision to ignore workplace safety for human services, we send a clear message about who we value. We're in the midst of a workforce crisis in human services, as we're all aware of, that's projected to get worse. Human service providers will be needed more than ever, and they're not going to tolerate working in positions that don't ensure their basic human rights. We must act on this now. I urge you to pass Senate File 1489 and show our professionals that we value them. Thank you, Madam Chair and members of the committee.
Thank you very much for your testimony. I also have on my list Beth Ringer and Makisha Hall. And please state your name for the record and begin your testimony.
Thank you, Madam Chair and the members of the committee. My name is Makisha Hall, and I'm the Director of Community Services at Model Cities. Model Cities exists to provide social and economic prosperity by providing access to opportunities that stabilize and develop families and communities. We provide housing and serve the most marginalized and communities and those that have the most barriers. Our families come from chronic homelessness. In my work as the Director of Community Services, my primary goal is to ensure safety of our staff as well as our clients. We try our very best to make sure that our workplace is safe, that through training and technology, our facilities is safe and structurally sound. We provide services that staff and residents that experience any safety concerns, we try to make sure that those are safe as well. However, due to the limited resources that are available, we are not able to always prevent any of these incidents from occurring. I'm going to share a few examples of safety resources that we use and that we need. First, we need more training. There's a need for our staff in our service area for active shooter training. Without this, staff won't be able to know what to do in certain situations, and it's creating threats for both our staff and our residents. These types of trainings are very expensive, and it puts a burden on our budget. We also need facility improvements. Working doors and buzzards are more and more needed, and we are outdated in our buildings. It's creating barriers and concerns for our families that we are trying to support. Recently, due to malfunctioning doors and buzzers, we are seeing an increase in non-residents entering and roaming our hallways to escape the extreme weather. This is creating an unsafe environment for our single families and their children in their homes, as well as our staff that are being put at higher risk for safety incidents with non-residents. Other safety improvements that we need are functioning lights and coverage for sub-level window bays to protect us from break-ins. We also have a need for follow-up support and safety incidents that occurs. Recently, there were bullets that went through our buildings and our windows for both our resident and our resident manager, and this deeply impacted our staff as well as our residents. We contract with a consulting firm that helps debrief these incidents that occur with our residents and a number of other services that they provide. It is extremely helpful, but unfortunately, this is a very, very expensive service that we have to afford. Human service agencies need these safety investments now to be able to help retain staff and ensure safety for everyone. We are doing the very best that we can with very little, and without these investments, we worry to struggle that we're going to be able to retain our staff as well as the services, and we might lose our staff. Thank you today for your time, Madam Chair, and the members of the committee.
Thank you very much for your testimony. And last, Beth Ringer.
Thank you, Madam Chair, members of the committee. My name is Beth Ringer, and I'm the Executive Director of the Minnesota Social Service Association. I also hold an MSW, and I'm a licensed graduate social worker. In my conversations with MSSA members, it is rare that I meet someone who does not have a personal story about a workplace safety incident. I want to tell you a story from one of MSSA's members, Megan, who's not able to join us today. Megan says, in October 2021, I experienced a physical and sexual assault while on the job. Soon after I started my job, I experienced a situation where I was threatened and yelled at. I did not feel safe going into the home again, but I didn't have the tools or resources to effectively communicate this or keep myself safe. Later, in September 2021, I experienced the joy of getting married. Prior to taking time off for my wedding, I received a case involving a client who needed to meet face-to-face. The events that followed at our first meeting were traumatic and have deeply affected my life. During that meeting, I was physically and sexually assaulted. I'm not going to go into detail about this assault because I want to keep the conversation focused on solutions. But at our first meeting, my breasts were grabbed, my crotch was touched, and I was choked. It was a living nightmare and has left me with a great deal of post-traumatic stress. I shared the journey of marriage in my life to highlight that I am a human, not just an employee and not just a provider. I'm a wife, daughter, sister, and now someone who experienced a traumatic event. This has not only impacted my ability to trust others, but increased my overall anxiety in day-to-day situations. I care deeply about my clients. I want to do my best work for them, and in order to do that, I need assurance that my safety matters. I need resources in order to keep myself and my clients safe. Megan's story is not unique. Workplace safety incidents are normalized in human services and are a critical part of the reason that workers are leaving or not going into this field. And this bill offers an opportunity for us to begin addressing this issue. Thank you.
Thank you very much for your testimony. It's sad that we have to be considering these issues, but it does point to the need for ways to address them. So, Senator Boldon, any comments before we go to questions?
No, open for questions, Madam Chair.
Members, any questions? Senator Abler.
And not really to the bill, although, holy cow, so sorry about all that. Just for a second, can the department come up and just tell us how they would go about awarding these grants? We just spent time when you were not here yet talking about FTEs to do designated grants. These are now going to be directed to all kinds of places. And just in like a 1 or 2 minute thing, can they describe how on earth they're going to decide who gets this amount of money? Because you could spend $100 million. So is anybody from the department here that could?
Is the Department of Human Services, is there someone who could address this?
Seriously? Of course. Got the utility player there, Ms. Grom. So I'm just curious, ballparky, like how you decide and to something laid out like this, how do you go about it and how big are they going to be and if it doesn't specify? So,
Ms. Grom, welcome to this committee and please state your name for the record.
Madam Chair, Christy Graham with the Department of Human Services. Senator Abler, I'll have to kind of dig into this amendment again, but it's my understanding that these grants are awarded on a first-come, first-served basis.
Yep.
So that's essentially, we would just award them based on, that direction in the bill.
Madam Chair, so
Senator
you would
Abler.
come up with an RFP and unless they're, and I don't even know if this, I'm just more interested in general. I mean, you heard if you're here for the original bill with the Maye Quade bill where somebody needed 0.15 FTEs to give it to one person for $260,000, we were wondering about that. And how much time would this take? Do you think it's a half FTE or is it to award this kind of money?
Ms. Grom.
Madam Chair, Senator Abler, we would have to determine that when we assess this for the fiscal impact, but we can certainly get back to you with that information. I mean, I think it was about a $10 million grant, so it's a fairly large grant, so it would probably take some administrative resources, but we can confirm.
And just, Madam Chair,
Senator
I'm not so worried about this particular one, but just in general, we've had this discussion as long as you've been on staff here and now at DHS, and so it's on our minds. And so, and maybe as we write these pieces of legislation, if we write them more carefully, it takes less work and it gets to who we want for sure. That's all. I'll leave it there. But I think it's an important discussion for later, especially offline. So thank you.
Okay. Thank you. I had a question. If the eligible uses are going to places, or eligible uses are for situations where it's a dwelling unit that the service provider owns, do we have, or I don't know if you can answer this or not, but has DHS had grant programs that would go for this type of, I'm looking under the eligible uses on page 2, like 2.13, and it sounded like from the testimony that there was a desire to have grants to upgrade things like security doors or that type of thing. Is there anything that we do currently that's similar to provide grants to facilities like that for that type of work? Ms. Brown?
Madam Chair, not that I'm familiar with. We know that Department of Labor, I believe, has workplace safety grants that they may currently administer or have in the past, but this isn't exactly our forte at the department. We do Medicaid under our HCBS waivers does allow for the payment of cameras, but not for the purposes of surveillance. They're really for the purposes of making sure that those cameras are meeting a person's specific needs pursuant to their case plan. So in a sense, we have parameters and a funding source for certain kinds of cameras and monitoring, but it's really tied to a person's individual needs, not a provider's workplace safety needs.
Okay, thank you. Any other member questions? This particular bill, we are going to have go over to the Human Services Committee because there is a lot of language around, having eligible uses in long-term care or other settings that are more in that committee's jurisdiction. Senator Abler.
Thanks. And if this, I'm persuaded about the needs, but you'll discover in the process, if you don't know, there's a lot of competition for the same dollars. And so if the authors and the proponents can figure out where do you wish this would go in particular, it'll decide whose budget it comes out of, because that's going to be an issue, because everybody's going to have more demands than they can handle. And what size the grants might be, and how you want to weight who gets it, and maybe some crime indicator, just trying to help you. Because right now, the sky's the limit. First come, first serve. One company gets all the money, you're like, yay. And then the good you want to have happen doesn't. So that's my advice. Thank you.
Yeah, Chair Wickland, can I add something?
Go ahead and.
Thank you. So Chair Wickland, Senator Abler, I just want to add, we do have eligibility outlined pretty specifically in the grant administration. Looking at what line it is, I'd be happy to discuss that more with you. So I'm trying to find it in here, but we do have specific eligibility requirements on the first page. So under subdivision, starting in section 1, subdivision 1, 2, and 3. But we're happy to add or edit things that you might think would be important there.
Sure, perfect.
And also, just to make a note, that there is a provision for the grant award sizes, at least 5,000, but no more than 50,000 for each individual applicant. So I think there are some constraints on how the money would go out, but I do think that's, more discussion is, and so we will pass this bill out to be referred to the Human Services Committee, and then you can have some additional discussion about it there. So members, if there's no other questions, Senator Boldon moves that Senate File 1489 as amended be recommended to pass and be referred to the Committee on Human Services. Is that your motion?
Yes, Madam Chair, so moved.
All those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and the bill is, Senate File 1489 is passed as amended and referred to the Committee on Human Services. Thank you. Thank you to your testifiers. And Senator Boldon, you have one more bill, Senate File 2108.
Yes, Madam Chair, and I would move the A1 amendment, which is some technical changes.
And that is being passed out. Senator Boldon, do you want to tell us, I guess, just where?
It's really just technical changes, Madam Chair.
Okay. So members, questions on the A1? It's an author's amendment. All those in favor of the A1 amendment, please signify by saying aye.
Aye.
Any opposed? The amendment is adopted. And do you want to introduce the bill, and then you can have your testimony?
Thank you, Madam Chair. So this bill is fairly straightforward, related to over-the-counter hearing aids. It is an MDH policy bill. So at the federal level, FDA and HHS adopted new rules, creating a new category for over-the-counter hearing aids intended to address perceived mild to moderate hearing loss in adults 18 and older. So as part of these changes, the FDA prohibits states from requiring over-the-counter hearing aids for adult use to be prescribed and dispensed by state certified hearing instrument dispensers or licensed audiologists. So this proposal seeks to update the Minnesota statutes to conform with the new federal laws regarding hearing aids, to conform to state statutes and the new federal rule and definitions. And I will just note that the Minnesota Academy of Audiology has expressed its strong support for this as well.
Thank you, Senator Boldon. Did you have a testifier? I'm sorry, I don't have a name on my list.
I do, yes, if we could move to testifiers, Madam Chair.
And if you could please introduce yourself for the record.
Thank you, Madam Chair and members of the committee. My name is Rick Michaels, and I am State Operations Manager for the Health Regulation Division of the Minnesota Department of Health.
Okay, thank you, and please begin your testimony.
Just to add to what Senator Boldon has said, specifically, the proposal would seek to respond to the federal law excluding over-the-counter hearing aid sales from hearing instrument dispenser and audiologist licensing requirements. The proposal would also amend the definition of hearing aid and hearing instrument to conform with the new federal definition. It would add other necessary definitions to various sections for over-the-counter hearing aid, prescription hearing aid, rebuilt hearing aid, used hearing aid, and bona fide evaluation. The proposal would add the term prescription before all references to hearing aid in various sections of the statute, with the exception of references to the title hearing aid dispenser or dispenser of hearing aids. And then references to repealed federal authorities would be deleted and replaced with new references established by the federal rule. I would note that consumers can still go to an audiologist or hearing instrument dispenser to get prescription hearing aids or to get a customized fit for their hearing aids. They just cannot be required to go to one of these providers by state statute. Thank you.
Thank you for your testimony. Any other comments? Members, any questions? Senator Abler.
Well, thank you, and I can't imagine the hearing aid dispensers. We're very happy about the federal changes. I don't see them here today, but what are they up to in this? Are they just, does this affect them? They can't stop it, or are they, I don't see them here today, but they've been a vocal voice in the past. Do you have any comments about what they're up to?
Mr. Michaels.
Madam Chair, Senator Abler, we have been in contact with the provider organizations and stakeholders on this. The federal rule went into effect on October 17th, so this is already effective. We've been in contact, like I said, with the providers, indicating how we've interpreted the federal rule and how we were going to respond, or how this would impact maybe our interpretation of the legislation here. As far, I can't comment, directly on any official capacity on what their thoughts are on this, but I will say that we have received their feedback and incorporated that into the proposed language here.
Well, thanks,
Senator Abler.
just Madam Chair and Senator Boldon, it would be, I'd hope that they're kind of always, they're getting smaller and smaller about how many of them there are, particularly I think with the changes. But just I hope that their thoughts are respected in this. And so that is a question if you could find a more affirmative answer since you're proposing the bill, and then I'm sure they didn't like the federal law changes because you remember in the past with the audiologists and the dispensers and all that, and trying to find some happy medium, which isn't always very happy. So thank you.
Thank you, Senator Abler. This bill is as Senator Boldon said, an MDH policy bill, and we will be laying it over. If we have further information when we take it back up, we can discuss it at that time. But I appreciate your testimony today, and the bill is laid over.
Thank you, Madam Chair.
And now, if Senator Boldon could chair for me, I would just like to get through this last MDH policy bill. It's very brief, and I don't think will be controversial. So hopefully, it's famous that isn't a good thing to say. So.
Senator Wickland, to your bill.
Thank you, Madam Chair. And Senate File 2210 is from the Department of Health and is one of their policy bills that they've submitted this year. It has to do with healthcare capital expenditure notification and reporting. And currently, all hospitals, outpatient surgical centers, diagnostic imaging centers, and physician or advanced practice registered nurse clinics are required to report to the Commissioner of Health annually on any capital expenditures over $1 million under Minnesota statute. MDH is required to retrospectively review all capital expenditures and notify each entity of the results of the review. In the event a review does not meet these criteria, MDH may require entities to go to the prospective review. MDH receives between 120 and 150 capital expenditure submissions each year. It has been over 10 years since MDH deemed an expenditure inappropriate. This suggested change in the bill would eliminate the requirement for MDH to notify entities of the results of their review unless the review determines the expenditure was not appropriate. MDH will still review capital expenditures over $1 million, but this will eliminate unnecessary correspondence with providers without affecting the development of evidence about planned capital investments in Minnesota healthcare. And we do have Department of Health, Stefan Gildemeister is here, but if you have questions about the bill.
Questions or discussion, members? Senator Abler.
I just can't believe it's a real bill, but so this just says that if everything is fine, they don't have to talk to the provider. Is that basically the change?
Senator Wickland.
Madam Chair, Senator Abler, I think the benefit is that the reviews are still being done. It's just that if there is not a reason that they believe that it's an inappropriate is the word. If it's not in an appropriate expenditure, then they won't have to go back to them. And
Senator Abler.
Well, thanks. And Madam Chair, Mr. Gildemeister gets paid by the appearance. So if he says his name, he gets a bonus. So if he wants to, I'm happy to listen to 20 seconds. Okay,
Mr. Gildemeister, please introduce yourself for the record and proceed.
Madam Chair, for the record, my name is Stefan Gildemeister. I direct the Health Economics Program in the Department of Health, and it's our team that takes in the capital expenditure commitments as part of annual reporting, reviews them, and then considers the very limited statutory language on whether or not things are appropriate. Typically, they are focused on whether or not the investment would be considered duplication, sort of the notion of across the streets MRI machines. To the question, which I'm now forgetting, I think what we're trying to avoid is just sending correspondence to providers who don't really need that. So they submit the reports. When they don't hear from us, they can assume that these retrospective reviews were not inappropriate. They can trust that they will hear from us when the submission or when the investment was considered inappropriate. So just saves paperwork and time on the side of the providers and on our end to prepare.
Madam Chair?
Senator Abler.
Well, I think there should be a fiscal savings of at least 0.15 on this one. So maybe we can, you can capture that, Madam Chair. Thank you.
Mr. Gildemeister.
Madam Chair, Representative Abler, this effort does not have an appropriation to it, so we do it sort of on the side of all the other activities. So we would appreciate saving time, actually.
Senator Abler. All right. Other questions, discussion, members? All right. Senator Wickland, any final comments?
No, Madam Chair, this is just another of the policy bills from department, and we will be laying them over and hearing some more additional MDH policy bills next week.
Very good. So Senate file, Senator Abler.
Just not on this, but now to follow up on your bill, I just heard back from the hearing aid dispensers representation, and it's peace in the valley. Everybody's happy, so they are monitoring, and they actually were interested. So I think you're good to go. I'm just happy to know that. I didn't know the answer.
Very good. Thank you, Senator Abler. And Senate File 2210 will be laid over for further consideration. And with no further business before the committee, we are adjourned.